A very good morning, good afternoon, good evening to everyone joining in from different parts of the world. A very warm welcome to each one of you to the Global School on Migrant and Refugee Health, broadcasted from Dhaka, Bangladesh. Now, the focus for the school this year is capacity building, and the session today is to build capacities to address the gender dimensions of migration health. Health needs, they differ across the gender. The health risk, the health challenges, the health conditions, they vary across the gender groups. The health-seeking behavior, as well as the access to the health facilities, there are differences in addressing the gender needs across the entire spectrum of migration health, be it in the countries of origin, during transit, or in the countries of destination. So this area particularly remains somewhat neglected. This area refers to the gender dimension of health overall, and particularly for migrants, it remains neglected. There is a huge gap and which needs a lot of capacities to address the specific health needs across the gender groups. We shall be discussing more on the addressing of gender health issues in the sessions which follow. Before I hand over the floor, may I now just read out some housekeeping announcements. My apologies for that. To all the participants joining in live, there will be a QR code at the end of the session. And so we encourage all the participants to please take part in the survey, scan the QR code, and your feedbacks are very important to us. Your experiences, your inputs will help us shape the future projects. All the recordings, presentations, and the video will be available at the end of the event on the events webpage. Towards the end of the day, you will have all this on the events webpage. Lastly, we encourage all of you to participate actively in the question and answer sessions using the Q&A feature of the Zoom platform. We are also looking forward to an active participation on question and answer session from the audience in the room. I now request the Director for Program Health and Migration, Santino Severoni, to kindly provide us with the overview of the day. Thank you.
Thank you, Arti. Welcome again to colleagues and participants. Well, yesterday was a quite exciting starting of the school. I'm very grateful and thankful for those who participated in remote and here in presence. It was interesting to see more than 1,000 people connected worldwide, precisely from 122 countries yesterday. And we were literally overwhelmed by the over 100 questions we received. We tried to do our best to address some of the most compelling questions yesterday, but there were few of them because of the time limitation. But we are committed to address them offline, and during the week we will communicate how the offline answer to the question are provided. Today, as you heard, is going to be the second day fully dedicated to two important topics: gender and right to health or human rights. This is a very important argument, very dear to us, also because when we are talking about gender, we are talking about women, and we are talking about masculinity. When we are analyzing how gender is impacting on the health outcomes of this population, we see different health outcomes or different risks associated with a gender typology, either woman or either man. And this is extremely concerning. We highlighted very clearly in the World Report that we released last July, how, for example, outcomes for migrating women are extremely poor in most of the contests around the world, or how men migrants being exposed to low pay, under provided security type of jobs, they are exposed to higher risk of injuries, accident, mortality related to job-related issues. So all this today we'll try to address all these issues We will going to have two beautiful reportages also today, and apologize, yesterday I was not correct. It's not going to be Colombia and Bangladesh, but it's going to be Lao People Democratic Republic reportage, and one from Bangladesh as well. Also today we will enjoy a keynote speech, try to connect the dots that you're going to see through the reportage and the discussions. So I'm stopping here. I'm not taking more time to the substance of the second day session and passing back the floor to you, Arti, and wishing a good day, second day to all of you. Thank you very much.
Thank you so much for providing us that overview. It sounds very interesting and we all look forward to. Let us now begin. And I have the privilege and honor to invite Anita Bhatia, Assistant Secretary General and Deputy Executive Director, UN Women, to provide her address. We have a recorded address. Thank you.
Distinguished colleagues, I am pleased to address you during this important forum. Addressing gender dimensions of refugee and migrant health is critical as inequalities contribute to the negative impact of displacement on women and girls and their access to life-saving health services. In 2022, for the first time, the number of displaced people in the world surpassed 100 million. People are on the move, escaping devastating conflicts, war, natural, and other man-made disasters. Women account for almost half of the 281 million international migrants. Along their journeys, they face heightened risks of sexual and gender-based violence, harmful practices such as female genital mutilation, forced marriages, maternal death and illness, and sexually transmitted infections, including HIV, as well as smuggling, trafficking, and lack of access to decent work and social protection, including, of course, health insurance. Compounding these challenges are their lack of safe access to available, acceptable, and appropriate health information and services. This has life and death consequences. Access to maternal health care is one of the greatest challenges for refugees and displaced women. In fact, 60% of preventable maternal deaths occur in humanitarian crisis settings. Information and safe transportation to health facilities remain difficult as most refugee camps are in rural areas or in conflict zones. And the negative health outcomes for women and girls in refugee settlements and displaced communities is, of course, tied to gender inequality, to discrimination, and the inability for women to actually realize their reproductive rights and to make informed decisions about their health care. This limits women and girls from accessing contraception, family planning, and other essential reproductive health services. Across the humanitarian development nexus, UN Women works closely with our UN partners, including UNFPA, UNHCR, WHO, UNAIDS, and IOM, to strengthen the capacities of humanitarian actors to develop gender-responsive health policies and strategies, and to deliver quality services to crisis-affected and displaced women and girls. UN Women's extensive experience in partnering with local organizations and women's networks have shown how local women's organizations are early warning systems for the gender-related aspects of forced displacement, migration, and humanitarian emergencies. In 2021, UN Women supported over 1,200 women-led organizations to influence the delivery of life-saving services for women refugees, internally displaced peoples, and other crisis-affected groups. Through our efforts, we have learned what we must have as essential in supporting access to health for women and girls. First, investments in gender analysis and collection of disaggregated data to advance durable solutions. Second, the scale-up of gender-specific programs which expand opportunities for livelihoods and education to improve women's knowledge of health rights and provide access to quality health services, especially for sexual and reproductive health. Third, gender-responsive humanitarian and refugee response plans, which include funding for women to realize these rights. And fourth, support to women's local organizations through investments in their capacities so that they are better able to participate in humanitarian responses and help to address the health needs of women and girls. Working in these four areas, we can collectively improve the situation of women and girls. Thank you, and I wish you success in your discussions.
Thank you so much. A very powerful and inspiring message there, clearly highlighting the needs to scale up investments in gender-specific programs, to have gender analysis and durable solutions by empowering the local women organizations. Let us now turn towards the video reportages. The first video reportage we have is from Laos, People's Democratic Republic. It's a country in the Western Pacific region of World Health Organization. Now, this country is composed of many ethnic minority communities, which are always on internal movement, and the internal movement in these communities is very high, particularly among the Hmong women. This internal migration is primarily driven by economic reasons. Let us look out on the video and learn from this video how we can build capacities to address their healthcare needs, particularly the antenatal healthcare challenges, how we build the capacities so that those can be addressed, specifically for migrant women.
คันสิเว้าแล้วประเทศลาวก็เป็นประเทศหนึ่งที่อยู่ในเขตตะวันตกเฉียงใต้ที่มีความหลากหลายทางด้านประชากรเนาะถึงแม้ว่าประชากรของลาวจะบ่หลาย7ล้านกว่าคนคันจัดตามหมวดภาษาแล้วละแม่นเฮามี4หมวดภาษาประมาณ50กลุ่มชนเผ่าในกลุ่มชนเผ่าน้อยลงไปอีกคันแม่นประมาณ150ชนเผ่าเนาะในนั้นประชากรส่วนใหญ่ละแม่นอาศัยอยู่เขตชนบทชานเมืองเนาะโดยเฉพาะแม่นชนเผ่าที่เป็นชนเผ่ามงและแม่นอาศัยอยู่เขตผู้ดอยจะหลายกว่าเขตทงเพียงนับตั้งแต่ปี1950เป็นต้นมาเนาะบ่เฉพาะแต่ประเทศลาวคิดว่าในบรรดาประเทศอยู่ในของเขตลุ่มแม่น้ำของนี่ก็มีประสบการณ์เคลื่อนย้ายถิ่นฐานของประชากรอย่างหลากหลายเพราะว่าช่วงนั้นอาจจะเป็นช่วงที่มีความขัดแย้งแดเนาะก็มีประชากรลาวที่ว่าเคลื่อนย้ายออกนอกประเทศส่วนใดส่วนหนึ่งเนาะแต่ว่าภายในประเทศเฮาเองก็ถือว่ามีความหลากหลายเช่นเดียวกันเนาะตัวอย่างว่าการเคลื่อนย้ายจากเขตชานเมืองเขตผู้ดอยลงมาอยู่ในเมืองนะหรือว่าเขตเมืองน้อยไปอยู่เขตเมืองใหญ่เป้าหมายก็เป็นเพื่อซอกหาโอกาสในการดำรงชีวิตที่ดีกว่าเนาะน่าสนใจและมันมีการรายงานของกลุ่มวิชาการทางด้านชนเผ่าค่ะเนาะในปี2022นี้เพิ่นระบุว่าแม่หญิงมีอัตราการเคลื่อนย้ายหลายกว่าเนาะหมายความว่าไกลครึ่งเหตุผลอาจจะเป็นโอกาสทางด้านการศึกษาบ่โอกาสในเงื่อนไขของการดำรงชีวิตบ่หรือว่าโอกาสในการพัฒนาตัวเองเนาะหรือว่าอาจจะแม่นย้ายกับครอบครัวบ่หรือว่าแต่งงานแล้วย้ายไปอยู่กับครอบครัวอยู่ของเขตอื่นจุดพิเศษคนม่งเฮาเนาะถ้าว่าแต่งงานแล้วอันนั้นมันจะต้องย้ายออกจากครอบครัวไปอยู่กับครอบครัวของผัวอันที่2มันย้ายย้อนว่าการเปลี่ยนแปลงทางด้านพฤติกรรมการทำมาหากินเช่นเดียวกันตัวอย่างว่าช่วงระยะการทำไร่ทำนาเนาะช่วงนี้บ่มีเวียกงานทำสมมุติว่าบ่แม่นฤดูกาลเขาจะก็ย้ายมาอยู่ในตัวเมืองตัวนี้ก็เป็นเหตุผลที่ไทยแม่หญิงเขาจะมีการเคลื่อนย้ายโดยเฉพาะมงเฮาก็คล้ายๆกัน
ย้อนลูกข้างเขาโอ้ลูกหรืออยาหมดตามเนี่ยถ้าอยากจะต้องมองเลี้ยเลยเนาะจะต้องมองมาอยากแต่อยากอันเดียวมาคุยกูดูเท่าป้าพวกนั้นอยากแต่ผมมองแต่อยากพวกอยู่มีอยากแต่ตอนเด็กแต่อยากมองนี่ชาวที่ชาวตาแต่ไหนอยากแต่อยู่ไปคือไล่แต่พวกหัตถ์อยากเลยเต้นเนาะจุดตัวนู้หัตถ์หูรอยอยากมองเลยที่มองแต่พวกตามองอยู่แต่จะช้ามองหัตถ์จะไล่มองหัตถ์อยากเลยคือไปต่อเมืองสุดแต่กูคิดเลยเหรอแต่是ข้าไปต่อสัญญาแต่ Tết trẻ thôi chỉ một số tôi thì nhiều gì chỉ một số tôi hú thì nhiều nhau ha nhiều sao ha lừa khó ấy à là cứ lúc thì bọn này nào là rồi nhiều mà nhiều chỉ nhau vậy nhiều gì sáng cả có lo thành cho ta chỉ nhớ rồi khó ấy thọ ấy bé một Tết tao mà nhiều chỉ một số tôi hú thì nhiều chỉ bao ta mình tụi mình nhiều là nhiều tụi cái này vậy thì nó có nhà rồi là chàng nhiều chỉ bao khó nó thì nhiều sao cho khó nó sợ cú ấy lấy ô nó lo lì nó là cú gì rong xa cả gì rong xa lấy cái gì lo dễ cả nhiều lấy mong số khai số sát rồi cho mình nhìn là bây giờ càng xa bây giờ rong xa rồi nhiều thì nhiều gì mà pro xa ta pro rong xa rồi nhiều thì nhiều gì rong xa
เป็นอย่างเป็นสิ่งกีดขวางให้แม่ยิงมุ่งที่ว่าเข้าถึงการบริการสาธารณสุขเขาเป็นสิ่งท้าทายหันและแม่นหนึ่งแม่นเรื่องภาษาปากเว้าเนาะเพราะว่าแม่ยิงมุ่งส่วนหลายและแม่นบ่ค่อยมีโอกาสได้เรียนหนังสือถ้าว่าในครอบครัวหากมีลูกชายหลายแม่ยิงจะถือว่าแม่นบ่ถือเข้าเรียนหนังสือฉะนั้นการสื่อสารทางด้านภาษากลางก็เป็นปัญหาหนึ่งอันที่สองและแม่นบรรดาสื่อข้อมูลข่าวสารต่างๆที่เข้าถึงกลุ่มเป้าหมายโดยเฉพาะกลุ่มม่งคือว่าแม่นยังบ่หลากหลายแล้วก็ยังจำกัดกลุ่มด้วยโอกาสอยู่แล้วนะแห่งเข้าถึงข้อมูลข่าวสารยากเห็นบ่เห็นได้ความสำคัญของการรักษาสุขภาพตัวที่3มากก็แม่นเว้าเรื่องในเด็กหญิงหนุ่มในชนเผ่ามงจะแต่งงานก่อนวัยอันควรเนาะตัวอย่างที่ประสบการณ์ที่พบมาเนี่ยบางทีแม่หญิงหาก็ได้แต่20 ปีแต่เรามีลูก4 คนซึ่งว่าตัวนี้แม่นโอกาสที่จะเข้าถึงการบริการทางด้านสุขภาพบ่ได้ดีก็ย้อนว่ามันมีความเสื่อถือบางอย่างหรือว่าการเคารพผิดของประเพณีบางอย่างที่ว่าแม่หญิงมงยังสืบต่อจะตั้งปฏิบัติอยู่ฮอดซุมื้อนี้เนาะ
สิกูรู้จอเตอย่างอยู่ไล่สุขาศึกษาจบเตขณะเตจอกปูยิงกันช้าหาจูรู้ละเขาหรือมองฟ้าปล้างมาอยู่มิโยเตปูยิงกันช้าดาวละปุ๊บพอมองละเจละเดี๋ยวตาจิตขาก็จิตปูยิงชีอยู่มิโยเจละเตปูยิงป้าตามองอยู่มิโยตาเมืองเตอยู่มิโยหมดเตลงตัวอยู่นะอย่าลงตัวอยู่ละลงตัวมิโยผู้ชีเตปูยิงป้าหลังดาวละcho em khổ em chỉ lấy một pháp lăng cho lấy họ mà thì họ ý thì cái thứ này chỉ muốn nhà vậy họ khó tôi thì chỉ sợ chết chết nhà này khó nhớ mà chỉ sợ hai lùm lo hết thì một thì tận thì chỉ tao muốn hai vậy thì một thì có hai thì chỉ bao dù hai là bao chỉ bao họ na thì hai chỉ nhớ lo sao tận thì họ lúc trước nó thì một mình nhớ hai thì một là chỉ bao hai lùm lo là hai lùm mông thế là nó hai là chỉ một cái nhớ là hai na hai sáng cũng mấy thứ mông luôn nhớ hai họอยู่ไล่มองจอนี่ชิปก็จะน่าอยู่แต่อยู่ไล่มองหาแต่ทำหมดแต่ตัวใช้แต่ชมเบลเราอีป้ามชมเบโจหาป้างเนี่ยนะตัวก็เยอะก็ป้าใช้อันนั้นตัวเหรอเราแต่ยังมาเล่นลูกชายแล้วอีอย่างนั้นคือลูกชายถอยตั้งสูลูกถอยน้องชายจะถอยตั้งสูน่าอยู่แต่พวกกูหมดแต่แต่是一起不รู้แต่我รู้เราหรือยังแต่不就是样น่าอยู่แต่ตัวอะไรเป็นอะไรเนี่ยแต่อยู่ที่ไรน้ำมันเลยแต่อย่าจอนดูละฮะนาลัวแต่มันจะไล่หัวหมอแต่พอตัวหูกูไปปั้งตูแต่กูตูไล่ถึงเยอะลัวแต่สิเขาเอ็นี่ปลดปล่อยดูแต่อยู่ใช้นี่ช่างก็ตาแต่ไปลงต่อนู้นฮะแต่ตะก้ามาตะก้ามันเล่นดูแต่หัวป้าโอเคแต่ก็เล่นอะไรวันนี้คือเรานี่มาหมดเราทางขี้แต่ก็จะมองหมอใช่ป่ะอย่างมั้งถึงอย่างอันนี้พิการนะอย่างแต่เกี่ยเราแต่พอยังมองหมอแต่เชื่อมสุดแต่พอหมดเลยแต่นี่ตัวก็จะไล่สบายไล่ช่างต่างนั่นแหละนะแต่ขนมแบบนี้ก็ไม่ทักแล้วอีอย่างใดก็ตัวแค่ไล่ดูออกมาตอนนี้นั่นละเขาลงชาร์จชับเลยแต่กูอีอย่างเดี๋ยวพออีตัวก็ปุ่มมือฝับล่างแล้วกูยี่ลงชาร์จแต่อีอย่างยืนรอนะอย่างแต่ก็จะรอmột cái lượt thẻ này hay là nó đóng để hay là một tuần sai hay gì mới ra đuôi họ.
Now that was a very beautiful video showcasing the real challenges which migrant women face on ground and what activities are ongoing to address these health challenges. Please allow me to mention that these videos have been exclusively produced for the Global School on Refugee and Migrant Health. These will be available on the event's webpage. It now is a time for us to have a keynote address, and it's an honor and a privilege for me to invite Virginia Wenger Garnier, the director of Meisha E, African Women in Germany. Her address, please.
Yes, thank you very much for inviting me on this third Global School on Refugees and Migrants Health Capacity Building. I am happy to be here today and I feel honored. Yeah, as a refugee girl whose parents left when I was 6 months old to Tanzania, and lived there as a refugee girl child for 13 years of my life. And having lived as well as a migrant woman in Germany for the last 38 years, I felt together with other women that it was necessary, in fact, to form an organization so that we can represent ourselves. And the issue of migrants' health is not only an issue of an individual nor a single community, but is a global issue. It concerns us all, and without health, in fact, we would be less productive. Maisha was founded over 25 years ago by African women in Germany who wanted to participate in public and also contribute to the health issues that affected them. In 2001, we proposed a health project because we felt that in the city of Frankfurt municipality, there was a group of people who were being left out of the system and were coming to us for assistance. In this case, I would just say when migrants leave their countries of origin, they live with the issues. Most of them could be gender-based violence, and most of it are not even being taken into consideration when we as service providers are dealing with their health issues. So for example, FGM, female genital mutilation, was the reason we felt that the city should cater for health of women coming from privileged countries like Kenya, Somalia, Ethiopia, and many others who were affected by FGM, because we believe FGM is a health issue. It is not only FGM, because we also realize that many women, when they leave their countries of origin, they come through trafficking. Some of them have gone through difficult journeys, and when they arrive, we find out that there are many issues like HIV, STI issues, and we felt we needed really to look into it, because we want to look at health, in fact, as a holistic, using holistic approach, and finding out the cause, how we can in fact go ahead and how we can make them be part of the society. In 2001, that's why we proposed this project, and the project was very much welcome, and it was not only to offer health, but was also to offer assistance in the system and psychological counseling. And we are happy that the city was happy, in fact, to welcome us and to be our partner. In 2001, we started with the African Consultation Hours for Africans, and we were surprised that many of them, in fact, they took the services and took it seriously and also saw it as their project. So they became part of the system and also part of the the services, because we were offering the services. And 2007, the city felt this project needed to be extended, and it was in fact extended to Eastern Europeans from Romania and from Bulgaria, and also neighboring countries, including migrants coming from neighboring countries who are in need of looking for jobs. And 2009, the center, in fact, became international. International Humanitarian Health Consultation was founded, and here up to today we offer services. As you can see, we are over 20 years we started this project, and we have been celebrating it with a lot of happiness, because our project has been, in fact, is a model project in the country, and not only in Germany but also other European countries has taken this model project as a success project, and have also implemented in other EU countries. Health is a foundation for us all, and nobody is an island, and here we think that it's very, very important if health is taken into consideration and taken very, very seriously, because if our health is bad, as a community we are poorer, and we cannot contribute to the societies, to our communities and society as we would like. However, because of employment laws, we found out that many migrants and refugee women are not able to contribute to the society even when they were helped, because of the system and their documents that they brought, the certificates they brought, education qualifications not being accepted. As for now, we campaigned a lot with other organizations, and many of their qualifications are now being considered, and they only can upgrade them. And this brings us to an idea that women come not only with without anything that we are the ones to give them in Europe, but we want to embrace what women bring from their countries of origin, because we found out that these women bring a lot of resources with them. We just need to integrate them into our own and make something new out of it. And I think by doing that, we would all be richer. This is our humanitarian consultation center. As you can see here, we are a diversity team. I am one of them there, and together with the doctors. And this is a place where we can offer help for those ones who are being not taken into the system and who feel not accepted in another system. And I could say up to today, we have been catering for more than 1,000 to 2,000 people a year, consultations as well. We offer workshops, and we think that it is not enough. I would like to say that it is not enough to offer only health, because around health, we need to know the cause, we need to know how are they living, what are the living conditions. We know very well you cannot tell somebody who has diabetes, you have to eat health foods, and this is what you need to eat. I only can eat those health foods if I can afford it. So we needed, in fact, to look into health as a holistic issue and try to see what is it that impacts on the migrant and refugee women's health. And we found out that we needed to do more activities. We needed to involve the women in everyday activities, that they don't sit at home, get depressed and feel helpless. And that's why we started our yoga courses. We offer German orientation classes. We offer dancing and singing for migrant and refugee women. And we believe up to now that many women can smile through our projects which we are offering. As you can see, this is our yoga classes, and women can come and they can in fact register with us, and we offer them a safe space. The other thing we do is making the women visible, letting the women participate, like showing their products, As you can see, this is handwork of the women. They were invited to showcase their work on a big supermarket, and they had stands for 3 days, and you can just tell their smiles that they really feel appreciated and acknowledged, and they're happy. This is our catering group. We offer catering. At the same time, we offer eating well by teaching the women who, in fact, when coming to new countries, they need to adapt to their nutrition, because what they used to eat in their home countries is different to what they eat here, and the foods that are offered, and sometimes they can't find it, and therefore they do not sometimes know what to buy, and also how to eat health using different recipes. And that's why we started catering projects, where we offer the community in our functions. We commit, and we also involve the women to be part of our activities. We have undertaken a lot of research projects together with Robert Koch Institute as an African women organization. I think that our contribution to the community for awareness raising on the issue of health has been really very well welcomed by the community and embraced at the same time, because when COVID hit 2020, we were the ones who, in fact, through the Ministry of Health in Germany, were asked to do the awareness raising, offer COVID-19 vaccination for those ones who felt they were out of the system. And we are happy to say that we were really able to offer the space and vaccination, full vaccinations, and utilize and also digitalize them. Currently, we are seeking to get many more our members from Sub-Saharan Africa to be part of our projects on STIs. Yeah, this is also supported by the health department of the city, and medically and financially. This is important because we believe that sexual health among Sub-Saharan Africa communities is not only their issue alone, but is a community issue, and we all need to embrace it and offer, include them in our health system, and build good relationship with the community as a whole within our systems. As you can see, this is our awareness raising booklets. We have STIs, we have awareness raising on COVID-19, myths and facts about COVID-19, because here we also saw that many Africans had a lot of beliefs and a lot of superstition, and we felt we should collect them and talk about them. So we did a survey, and out of the survey we did, in fact, we came out with a booklet. We also have the awareness raising on FGM, female genital mutilation. Then we have health nutrition, and many more other issues. You can look at our website, you can see what we really do. This was our MISA, is STI, together with the Robert Koch Institute, where Maisha coordinated in the city of Frankfurt. And we involved, in fact, in this study, we involved 16 health mediators to champion the STI issues, because we felt that it is an issue among the Sub-Saharan Africans in Frankfurt. This is the campaign of the vaccine on COVID-19. And also as a model project in Germany, we were able, in fact, to reach out to more than 15 to 16,000 people through our campaign within 1 year. This is our campaign for vaccination, And we do that monthly, offering the vaccination. Now we are on the third vaccination. This is our information with the pregnant women, where the women participate to our programs. They learn about the German health system. They learn about what is required when going to the gynecologist. They also learn about health foods for pregnant mothers. They learn about breastfeeding and the requirements within the health system, and also the offers that the city and the health system in Germany offers. The other issue is that we felt that there were a lot of issues that made women not feel part of the system. One of them were, for example, depending on a brother or a husband, employer, and we realized that most of the time, if you depend on somebody, your needs may come short for you, because not everybody wishes everything good for you. So here we felt that we needed to do more. And in fact, what we do is try to reach out to the women themselves and give them the information that they need in a simple language and understandable language. Marriage that could be abusive need a lot of courage for the women to come out to speak about it. And it doesn't matter whether you're a refugee woman or a migrant woman. We know that is a taboo, and that's why we put a lot of focus on domestic violence, to inform the women in the new country that they have the rights and that violence against women in Germany is a crime, and they can report it and we can support them. Pressure for not succeeding. Many of them, since they arrived in Europe, the relatives back home believe that they are doing very good and they should now be the ones to provide. And this pressure can mean a lot, even cause up to depression, and also cause a lot of them, even when they are rejected as asylum seekers, not wanting to go home, and becomes an issue, because without documents, you cannot do anything, you cannot work, and the life becomes difficult. Living in fear of deportation is one of them. Being found out if in fact your asylum has been rejected and you have been asked to leave the country, or marriage that failed. The law still in Germany says 2 years in the marriage, even sometimes when it's abusive, and 1 year separation, and these 2 years in a marriage could look like a lifetime, and many women get traumatized, and sometimes domestic violence has an impact on the health of the women. The many women who we come to us for counseling also identified the lack of willingness when coming to health for them. They felt their identity was uprooted from where they come from, is not integrated in the countries where they are living now, and they feel sometimes rejection. The list could be longer, but at least there are a few more. And the lack, for example, of understandable information can become very, very difficult, because without translation becomes, you cannot, especially the German language is one of the most difficult languages, I would say, and you need somebody to assist you in your first years when you arrive into the country. Misunderstanding due to medical professional language has also been reported by the women, that here they need support, and simple language is needed. Lack of cultural understanding by some of the health providers. Lack of sexual and health reproductive rights should also be taken very serious. As I had said previously, violence against women has an impact on their health, and in many cases, women during the COVID-19, since 2020, we realized the number went higher. Women are depressed, who suffer from domestic violence or violence at all, and didn't go for treatment, and they also did not report. Lack of cultural sensitivity is also the other issue, social discrimination and stereotyping. Yeah, we have a few recommendations because the women, also the women and their children and their families think political willingness here is important for us to succeed in offering medical services for refugee and migrant women. States should also have and take appropriate measures to eliminate discrimination against women in health care facilities. Ensure equal access to health for men and women is accessible. Grant free services is also very important because women feel that they need to be part of the system, and we think that also simple things like when we talk about health, we also believe that nutrition is key, and nutrition for women who are pregnant and breastfeeding mothers is very important in the life of a newborn. Ensure that there are also adequate number of functioning health center facilities, services and programs related to maternal health care, because it is we need them all in every state. Well-trained health providers and a diversity of health providers to enrich culturally. Health and maternal care services must be accessible to refugee women without discrimination, both in law and in practice. Maternal health facilities, information and services must respect also principles of confidentiality and informed consent, because here we should offer also services without having to take the data of our clients if they wish so, and also ask them if they understand what the data in our health system mean. Culturally appropriate and take into account the interests and the needs of refugee and migrant women. Culturally, it's very important. In fact, whenever we have people coming from different countries, to be more open to listen to them, because nobody knows better than you yourself about your health, especially when you have a different language to describe your health issues than the country you are in. I think here we need a communication which we from both sides to understand each other, and sometimes we can avoid misdiagnosing some of the issues that sometimes appear when women say their diagnostic they were given was wrong, or they did not understand. You should be able to understand if you go to your practitioner. Independence and legal status is very important for women to empower themselves. Clear and simple procedures for acquiring permanent status for regularization in the country of residence is as well very important, because many women who are with us, some women have been waiting for their asylum procedure for over 10 years, 15 years, and do not know whether they are going to be accepted or rejected. I think after some time, you should know where you belong. You should know whether you are at home or you are going back home. But after 10 years, even where you came from, you have a question mark. And me as a refugee child, And as a migrant woman, I would say this point is very, very important, because this is what decides whether I will really ever feel integrated in the residing country or not. And we see many times that migrants and refugee women stay under those circumstances. And we hope that in future we can really work on those issues faster. Full access to basic rights, including health, is also very necessary. Development of cultural sensitiveness when providing services to refugee and migrant women is also very important, because we all know that we all have different cultures, we have different beliefs, and we have different health systems. So that is already something which can be can enrich us, can become a barrier, or can become something which we could call enrichment into the new society. So here we should look more how can we understand each other? And it's not one way, it's a two-way. Thank you so much for your attention and for inviting me.
That was amazing and a unique experience. A migrant African woman dedicated purely for migrant women empowerment. Thank you so very much. I would like to inform the audience, we have Virginia Wanger with us online, and she'll be very happy to address all your queries and questions. It is now time for the video reportage from the largest refugee camp settlement in the world, the Cox's Bazar, our host country. Ministry of Health Bangladesh, with support from World Health Organization, has invested a lot in capacity building of the healthcare workers to identify the gender-based violence victims through interactive sessions. Now, these interactive sessions and trainings are what we are going to give a glimpse of during this video reportage. May we have the reportage, please?
I am Amina and I'm 18 years old. My father is the chief in the village and my mother is an important woman. My brother and sister are younger than I am, but we all used to study, play and work together. That was before all the trouble started.
1 in 3 women globally have been subjected to physical or sexual violence in their lifetime. For migrant communities, that figure can be as high as 1 in 2. Getting these women the care they need is a critical part of the migrant response in Bangladesh. Alongside the Sexual and Reproductive Health Working Group and GBV subsector, WHO conducts training workshops to ensure quality clinical management of rape and intimate partner violence services during the Rohingya crisis.
I'm called Samrarita Safa. I work as the gender-based violence in emergency specialist in Cox's Bazar. The WHO acknowledged that health services for GBV survivors are very vital, are very life-saving. By building the capacity of doctors, midwives in the area of CMR and intimate partner violence, we make sure that they treat survivors of GBV the right way. It's only not about knowing the technicalities, it also has to do about the feelings.
Today's compassionate referral training puts participants in the shoes of a survivor of gender-based violence. In following their stories, health workers will encounter the same difficult choices and no-win scenarios. Facing these difficult decisions give participants a better understanding of what it means to be a survivor.
Hi, this is Mohammad Ashrafur Rahman. I work as a GBV program analyst with UNFPA here in Cox's Bazar. My character here is Naima. She is a 28-year-old woman, a single mother. Her husband left her. She has 2 kids, twins, and she is kind of like managing by herself to feed her children. She became a sex worker eventually, and after working for a few days, she developed sexually transmitted disease. I mean, I really put myself in Naima's shoes. That person could choose this path because she literally has no other choice to go, right? So from that angle, I feel like definitely nobody should judge anybody without knowing her story.
This training gives health workers an opportunity to reflect on barriers to quality care. A more compassionate referral service means survivors are more likely to get the support they need.
At the end of each story, they were posed with options. It could be 2 options, it could be 3 options. And as they were choosing, many of them were very irritated because the options were very limited. The options were also not the best options. I have seen participants and they were mentioning that they were really angry. Some of them also wanted to cry because they felt like this is what it means to be a survivor.
If I am Amina, so maybe I feel that it's very hopeless for me, helpless for me. I mean, I will totally destroy myself.
Why the hell you are doing this? Why you are doing this to a woman? Like, she's a child.
We had today is Betty's character, who really loves very much to go to school with her another friend, Fauzia. They had lots of hopes, but yes, unfortunately, when Betty's parent and both Fauzia's parent decided to marry them off. We know that being GBV or case management actors, we have to have empathy on the survivor, but based on these stories, it gave me actually another chance to think, give the survivor a space, a safe space, where the survivor can, share all the situation she went through and seek support.
Compassionate referral is just one of a package of trainings provided by WHO to cater to gender-related health challenges in Bangladesh.
One of the biggest components that we do is provide trainings or capacity building on clinical management of rape and intimate partner of violence. In addition to this, there are other components as well where we do quality assurance to make sure that there is available service, but also to make sure that the services that we provide are also of quality.
At the end of each session, participants are asked to discuss their experiences.
So at the end, when we debrief, and it's very important that we also focus on how they feel.
And also maybe reflect a little bit. Can we make it a little bit easier? What can we improve in the services that we provide?
An individual can be very unlucky actually if she or he is not supported well by the family in the first place. Because in Betty's story, where she had lots of hopes, dreams, and a good friend, but everything got, destroyed because of the decision made by the parents.
Being a man, probably it's not possible at all to understand how a woman goes through when she is as a survivor of gender-based violence. But maybe this is one of the ways to go through those stories, put ourselves on their shoes.
I'm the health service provider person, but I also see that maybe one day we need to care like 30 or more than 35 people to giving the service. But we need to think every single person, how difficult they are going through and how significantly they are seeking their help from us.
Violence does not happen to only one sect of a community. It happens to any woman from any background. She can be rich, she can be poor. It can happen to anyone and everyone.
Be empathetic.
Being non-judgmental is a key. Everybody has a role to play.
Every service provider need to come in one umbrella.
I think we need to be honest and we don't need to make any false promises to our survivor. So being polite and being honest is most helpful for them.
Get yourself educated as much as possible.
Survivor knows best for herself what is good or what is bad for her.
Treat all individuals with respect and dignity.
Thank you so much. That was a very informative video. Now that brings us to the very interesting session, and that is the question and answer session. I'm very happy to note that Virginia Wenger, our keynote speaker, as well as Anjana Bhushan, Technical Officer for Gender, Equity and Human Rights at the Southeast Asia Regional Office of WHO, are connected virtually to the session today and are very happy to address all your queries. I will now request James Carmichael, the External Communication Officer at WHO Cox's Bazar Sub-Office, to please take the floor. He has been very actively diligently noting down all the queries in the chats and question answer sessions. I would request him to moderate the questions, and the floor is open for the audience here in the room to please ask all the queries you have.
Thanks very much, Arti. Firstly, can I just get our guests joining us from online to please turn their cameras on, their webcams, so we can see their faces when they answer the questions? That would be fantastic. So firstly, I'll ask if we've got any questions from the audience at all. Any hands raised? Nope. Okay, I'll dive straight into online questions then. This question comes from Krishna in Nepal, and they're asking Santino and Arti, when we talk about gender amongst refugees and migrants and their health needs, what are 3 things that have been successfully accomplished, and what 3 issues or challenges still need addressing? And I think they mean on a global level. 3 things, yeah, three things that still need addressing and 3 things that have been successfully managed so far.
I would request Santino to please take the lead first.
I will be very telegraphic, maybe a couple of tweets. I think a big achievement is that we have clear competencies to address gender issues for healthcare workers. This was a big caveat, and today this has been filled up. We have a clear definition of the competencies. What is still missing? The process of rolling them out and implementing them is still at the early stages. So we need more attention, we need more participation, we need more engagement. Those are the 3 things which I would require. Gender, certainly it's widely recognized to be a priority inside and outside WHO. And this needs to be transformed into action. So it's really time to act now.
So the recognition of gender itself is a success. The focus on gender dimensions. What we have is realizing that the gender dimensions need to be addressed across the entire phase of migration. That itself is a success. The work has begun, but a lot has to be done. So that it is the recognition alone is not enough. A lot of capacity building has to be done, and a lot is already on ground, which we've learned today. I also feel that something which is missing is the gender is not only male and female. What's been recognized is the entire LGBTQI spectrum. Those people during the vulnerable, especially the refugees and migrants, have additional needs, which also need more attention and focus. Thank you.
Fantastic. Thank you very much. This next question comes from Monica in the UK, and it goes to Virginia. Virginia, what are the main challenges and difficulties that you face whilst founding your association? Do we still have
hello?
Oh, here she is. Great.
Yes. Thank you for the question. And I think the main challenges for us when the organization was in fact the language, the system we didn't understand, even founding an organization, we needed support. And I think the funding was also crucial.
Fantastic. Thank you very much. Any questions from our audience yet? Does anyone like to raise their hands? Nope. Okay. Over here. Sorry. Please go ahead.
Thank you. From our Triple RC side, so I have some observation about. It's okay.
Please go ahead. Yeah. Technical glitch.
So in the say like hepatitis C, it is about 18-19% in the refugees. Hepatitis C and HIV also side by side. So need to be concentrate on this because it is every time it is increasing. Thank you.
Any comments from the panel? Oh, okay. So, yep, we got another question from the audience. Thank you.
Thank you. I'm Dr. Sukarna Priti. I'm working with Canadian Red Cross as a country focal of Bangladesh delegation. I'm working with the refugee context since the beginning. And this all time we are sensitizing the migrant people in the camp settings, but we are not concentrating our colleagues. They are also experienced a lot of violence, not only in the office, not only in the roads, also in the families. Maybe they are dedicatedly working, but sometimes their family may be encouraging, and sometimes they are facing some problem. Please don't go, don't do this and that. But they don't have any room to discuss their issues with the colleagues. And sometimes colleagues are also taking some advantages, and it is going on. And this when the female are talking, then female are sharing something, but we don't have room to share these things. So we need to make a forum where we can go and we can discuss these issues. If I'm not in mental health, then good mental health, if we don't ensure, then how we can expect that we can ensure the better services? This is my experience, and I hope so one day it will be overcome. Thank you.
Thank you so much. That was a brilliant intervention. I would like to just highlight here that preventing and responding to sexual exploitation, abuse, and harassment is a prime focus of UN organizations. I would like to give the floor to Anjana Bhushan, the regional focal on PRSEAH, to please add a few words.
Thank you so much, and good evening, good afternoon to everybody who's logged into this event, and also those live on the floor. It's a pleasure to be here and join you today. On the prevention and response to sexual exploitation, abuse, and harassment, I wanted to echo my colleague Arti's words to let you know that this is an area of high corporate priority in WHO. We are now doing, we're in a period of accelerated attention and focus to this issue. We are on the brink of launching a 3-year strategy, an organization-wide strategy to address this issue. And this issue, our strategy is grounded in the principle of zero tolerance. Zero tolerance to perpetration of sexual exploitation, abuse, and harassment in the communities where we are serving, but also zero tolerance to inaction against it. And so we're overhauling our capacity and our procedures and our systems and moving towards a risk-based approach, trying to assess the increased risk of SEAH happening in contexts like Cox's Bazar, which is a large refugee settlement, or in other emergencies. And also we're moving towards a victim and survivor-centered approach with a focus on the needs of victims and survivors, whether those are financial assistance, psychosocial support, legal referrals, and so on and so forth. Importantly, we're also training all our staff and raising awareness among partners, including implementing partners and our contractual partners, so that people acting in our name also have the awareness and the accountability to effectively prevent as well as respond more rigorously when incidents do occur. While I have the floor, if I may, I'm also the focal point in our office on gender, and I noticed several questions in the chat, as well as one or two from the floor, around successes and challenges, around the stigma on violence against women, and so on and so forth, and how to make sure survivors have services, how to increase gender responsive programming. I'd just like to say that WHO is working with partners, and you saw an example of this in the video from Cox's Bazar, but in addition, we are working with our UN partners and local partners on the ground to build the capacity of the health sector as part of a multi-sectoral approach, both to preventing violence against women and to building the capacity of the health sector within a multi-sectoral response. So our health sector, evidence shows that health professionals are uniquely placed to respond because women are likely to disclose their abuse to health providers. And we're building their capacity to deliver compassionate first-line support and also linked to referral. We're also working on prevention through our evidence-based guidelines, which have the acronym RESPECT, R-E-S-P-E-C-T, and each of the letters in this acronym stands for one or another strategy. For example, E is for empowerment, S is for services, etc. On gender responsive programming, I'm happy to report that WHO has a range of technical tools and resources to build the capacity of the health sector to undertake gender analysis, to understand whether its programs and interventions are gender responsive or not, and how to make them more gender responsive, how to build a gender lens into our policies and programs. And we're gradually working at the level of policy advocacy, capacity building, evidence strengthening, and advocacy and partnerships to take this agenda of gender responsive planning and programming forward. Thank you so much for giving me the floor. Over.
Thank you very much. So Lily Bismarck from South Sudan asks, in addressing gender issues, we see a lot that's done for the female. What's being done for the male? And that's a question to everybody.
We do understand that women, they are the ones who suffer from bigger cultural barriers for the accessing health, not only in the migrants, but also in the host community. And when we talk of migrants, they're more than 50% of the people on the move are women. The example for Lao talks about women who move about internally also for socioeconomic reasons. So the point I'm trying to drive is that women are the one who are more at the receiving end. Certainly, a lot has to be done for men, but we've begun building capacities to address where we know that the gender-based violence victims are primarily women. It is an area where we all will focus on. And as they say, a well begin is half done, but we are yet to achieve a lot. We do recognize that there is a need to address the migrant health, the gender-based violence among the males in the migrant as well. I would also give the floor to Virginia to please supplement. Thank you so much.
Yes, thank you again. I think when we started our project, we started as a women organization for women. And very quickly, we found out we needed to include men because there were health issues which also, without the men, we would not have been able to solve. Like when we talk about sexual transmitted infections. So we needed to talk with the men, and where there were gender violence, we also needed the men, and we tried to make it to include the men in our project, and that's why, in fact, it's not only for women, but men are also included in our services. So we think it's very important when we are dealing with health.
Thank you very much. This question comes from Monique. Sorry, please go ahead. Sorry, please go ahead, Angela.
Yeah, thank you so much. I just wanted to answer the question on men. I just wanted to make 2 points to echo what my colleague Virginia said. One, WHO's own evidence shows that involving men, especially in their father roles, improves maternal and child health outcomes. The other is that gender is about how gender norms, roles, and relations affect both men's and women's health. So it's important to do gender analysis to understand how gender norms, roles, and relations could be affecting men's health. I'll give you an example. Smoking uptake. Tobacco smoking is much, much higher in our region among men than women. And so a tobacco control program should understand what are the gender-related norms. There's nothing biological about why men and boys take up smoking. So what are the gender norms that drive them towards smoking? Cigarette companies have figured this out, and they are actually having gender-specific marketing strategies to boys and girls, and they're in fact successfully marketing to girls that rates of uptake among girls are now becoming faster than boys. So the short point is that we need to understand how gender plays a role in influencing health risks, health-seeking behavior, and access to health services, our experience in healthcare settings, and indeed health and social outcomes. And gender analysis will uncover these for us, whether it's for men's health or women's health. Thank you so much.
Since the question was for all, I would also request Santino to please add.
Thank you, Arti. Well, thank you, Anjana, for bringing up this perspective. Indeed, both gender might be linked to increased risk or might be influencing the health outcomes according to gender, let's say, based behavior or experiences during the migratory process, let's say. I want to just to add to what the colleague from Seattle said, that there are interesting findings and data in the World Report we just published. There are also specific reference to this region, but to the entire world. And it's interesting to see how the different society role actually generate exposure to different risks of the male or female gender as well. So really, I would like to use this opportunity to encourage to read that part, because it's extremely enlightening. Too often we think about gender, woman, and not also the masculinity as a possible element of risk or a poor health outcome. Thank you.
Thank you very much, everybody. Very detailed answer. This question is also from Lily, and it goes out to Virginia specifically. Lily says that she has a vision and a dream to do work like you're doing in Germany, also in South Sudan. Are there any platforms or education, mentorship, training courses that she can attend for someone like her who has no experience at all in this kind of service?
Yeah, in fact, what we have been
Virginia
doing so hard. Yes.
Sorry, Virginia, you're cutting in and out a little bit. I think we have internet connectivity problems. What I'll do is I'll circle back to that question and just ask it a little bit later, see if we can get a better connection. So this question comes from Monique in France, and it goes out to everybody. LGBTQ plus migrants are strongly marginalized. Do you have any further reflections on this? I know Artie's mentioned it already, but our audience would like to hear more about that.
I would request Anjana to please respond to that. Anjana, floor is yours.
Could you repeat the question, please?
Yeah, absolutely. So LGBTQ plus migrants are extremely marginalized worldwide. Do you have any further reflections on that?
Yes, I would say this is true. And in the data on LGBTQI community it shows that they have higher health risks. There's often a lot of stigma and discrimination that they face. And the health system and healthcare providers don't understand their specific health needs. And often services are delivered in a way that are not tailored to their needs and issues. So I think that if we need to be equitable, gender responsive, and human rights based in our approaches, we do need to understand the particular needs that the LGBTQI community among migrants faces and make our spaces, our policy spaces, our program discussion spaces safe for them. I think a key principle is participation. This comes from the HIV community, which said nothing for us without us. So one very effective strategy would be to engage LGBTQI communities belonging to the migrant group in the design and implementation and evaluation or monitoring of health policies and programs designed for migrants. So their participation is an important part of the solution. Another part of the solution is to train healthcare providers in the specific needs of this community and what kind of health issues they face and how we can tackle these issues, including actually violence against LGBTQI. And a third is at the level of the human rights agreements, several of which are devoted to the rights of this community and to advance those rights through corresponding national laws and policies. Over.
Thank you very much, Anjana. Would anyone else like to weigh in? Okay. Virginia, do we have a connection? Are you with us?
Still there.
Excellent, fantastic. I'll circle back to the last question then. Just as a reminder, Lily from South Sudan was asking, she would very much like to do some activities like you're doing in Germany. Are there any platforms, education opportunities, mentorship programs that she can subscribe to that will equip her with the skills she needs to do what you're doing?
Yes, in fact, we found out that we wanted to know more because the migrants, when they come to Europe or to other countries, we found out that what is happening in those countries, we needed to understand and also to know. So we started a program and projects called Transcultural Health Knowledge Sharing. And in fact, we mobilize, like in Ghana, we train health mediators, and maybe we can see how we can cooperate in some of those projects, because we have also a lot of experience, and we have also been offering training in Kenya as well. We train health mediators in their communities.
Wonderful, thank you very much. This next question is from Shah Bani from India, and it goes to Santino. Santino, what does the WHO Global Report have to say on gender inequalities in refugee and migrant settings?
The report highlights the situation worldwide, and unfortunately, the picture which is coming out is still quite concerning in terms of health outcomes related to gender. Particularly the access to essential service remain highly neglected to different contexts around the world for women, pregnant women. The element of gender-based violence remain a big issue around the world, but also, as I was mentioning before, came out quite surprisingly, the increased risk of trauma and other form of injuries for migrants, male migrants migrating and employed into low qualified type of jobs in different contexts in the world. Thank you.
Thank you very much. This question goes out to Arti. It's from Bereket. If the migrants give birth in a refugee camp or development, how is the citizenship of the newborn defined?
So we have the WHO colleague who heads the largest refugee camp, Dr. Jorge. I would request him to please explain how it works in the refugee setting.
I think I'm going to pass the buck. No, I send UNCR colleagues, please. No, I'm going to pass the buck, but because the right registration process, I think belongs to our colleagues. So I'm really requesting support here to be properly.
Thanks for that question. I just respond. The citizenship is usually tied to your country of origin. We encourage, UNHCR promotes birth registration for all babies who are delivered in refugee camp, because that registration offers protection to the refugees and migrants to access other services as well.
Thank you for the lifeline.
Thank you very much. So this next question is from David Mosca in Italy, and it goes to Virginia. Many times the issue of migrant participation is raised. What's your experience with government and local administrations? Do you work with other civil society organizations, and do you have a common table of coordination? Great question.
Yes, I think the question is very good because, in fact, as you can see, we are based in Frankfurt, and since this program for health and for very vulnerable group, we needed to sit within the city to have a table. And in fact, we do have a table with the city of Frankfurt, the municipality, and at the same time, Maisha sits on the national table from the German government on recommendations and working on the issues of health in the whole nation. So we have a table, and we have on the local level and on a national level. And on a European level, we also are in the network of PICUM, and also within the European Commission, we are also involved with the Anti-Trafficking Commissioner. Alone, we cannot do it.
Thank you very much. This question is from Olga, and it goes out to Arti. Is the content of the training we saw in the Cox's Bazaar available? Maybe.
Again, I'm looking at the WHO sub-office head, Dr. Jorge, to please provide if the content of the training, which we have the interactive sessions available.
So Dr. Simon, maybe good to answer this. This is regarding the In Her Shoes training.
Yes, thank you very much. This training is available through even the bigger partnerships under the gender in humanitarian agencies working groups. And I think if the contact is available, then we could link up and provide access through the relevant channels. Thank you.
Excellent. Thank you very much. Next question from Claudia from Italy, and it goes to Santino and Arti. How can the WHO promote the sharing of community-based experiences amongst civil societies, just like the ones that Virginia presented to us?
I think we are doing our best, and this is one of the platforms where exactly we are sharing the community experiences. We understand the more we share, the more we learn. So there are a number of platforms. We also take into consideration the public perception and voice of the community. And I would request Santino to please supplement.
Well, indeed, there are a number of initiatives and a lot of energy to try to share what we know. But the point is that we don't get to know all that we should be know happening at the community and country level. What I mean with that, when we are looking at the work in the health sector through the length of community level engagement and health and migration or refugees health, what is happening is that there is a very limited documentation. I was discussing this also today during another meeting, that really we should invest also substantial energy in advocating with countries, with communities, with partners, with international organizations, NGOs, to also devote some energy. When I'm saying energy, means time and resources, to research, to quality research, and to document what they are doing. We are learning every day about wonderful initiatives, wonderful experiences, but then when we do a systematic review, when we look into the international official literature or gray literature, those are not appearing, simply because we are too often too busy into implementing, into working, rather than documenting what's going on. So this must to be a key element of our daily work. And this is happening for central government, regional government, international organizations, and also local community. However, the local level is perceived to be extremely important in our work. Personally, I like to say that to be impactful on working on health and migration, you need to be thinking globally. So I'm playing with the words, thinking to global issues, but to really act locally. So a global approach should be our driving force into our action. And it's true that there are also very solid, very well-defined networks which are bringing in the community level. So indeed, this is a very important aspect. Also, the community participation, the community action is well reflected into the UN network on migration for the implementation of the Global Compact, but more we need to do in documenting different realities, more we need to do in making available good practices, so that not only we are informed, but this can also inspire the work of other realities without getting lost into duplicating or replicating what has been already done, or re-experiencing processes already well known. Thank you.
Thank you very much. So I just want to note that we've got around 80 questions pending from the audience. So I'm sorry we can't answer all of them. We're doing our best, but we'll think we've got time for one or two more. This one is from Ivana in Croatia, and she'd like to ask Virginia, firstly, congratulations on your great work, she says. And how important is it to involve migrant women in delivering the trainings that you deliver?
Yes, for us it is very important, because as a women organization, we in fact target the women. We believe women can make a change. It's easier for the women to reach the women, and it has in fact paid out. It has paid out because women come to us even when they are rejected and don't have any health insurance. We help them. We help them without any documentations. Sometimes you have that kind of group which is very vulnerable, and also vulnerable situation where they are scared to go anywhere. We have managed, in fact, to give them a space. And the other issues is that it is important to look into issues of women, because we are not equal. Even when we talk about gender, We are talking here about women. We are talking about pregnant women. We are talking about trafficking of women where they are taken into sexual industry. We are talking about, in fact, FGM, honor killing. So the issues of women are different to the issues of men.
Fantastic. Thank you so much. Okay, we have run out of time just there, unfortunately, but all the other questions will be addressed in writing where possible. So please look for those replies. I'll hand back over to Arti. Thank you very much.
Thank you so much. It really shows a lot of interest and a lot of active participation. We are so happy to have each one of you join in today. My special thanks to Virginia, my special thanks to Anjana to be connected and also helping us address all the queries. We are now coming to the end of the session. And as they say, all endings are new beginnings. I now hand over to Santino to please provide what we begin tomorrow. Thank you.
Thank you, Arti. Let me join you in thanking all the speakers, but also particularly the audience in presence and in remote for today's session, for the day 2, on a very complex topic. We understood already, we knew since the beginning that today was going to be just stimulating thoughts and discussion because the subject is quite complex and extensive. Tomorrow we have another important day. We will focus on capacity building for culturally pertinent healthcare. Tomorrow we will have 2 beautiful reportages as well, one from Chile and one from Kenya. So we are changing geographic location, and we will have also contribution from key partner organizations, from IOM Director General and keynote speaker as usual, to connect the dots and to analyze, deep dive into the topic. We look forward to have you all tomorrow, same time, same link, same format, 4 o'clock at the Dhaka time. Thank you very much for your for following us and for your attention and enthusiasm. Thank you.